So why don't we have each of the panelists introduce themselves? Dr. Morris, would you like to start?
Sure. Can everybody hear me? I'm Dr. George, and many people know me as Chip Morris. I'm currently the president-elect of the Wisconsin Medical Society. I'm a neurologist, and my field of expertise is actually epilepsy. So the field of pain management and opioids is kind of a, we'll call it a hobby employment. And so I have served as the chair of the Opioid Task Force for the Wisconsin Medical Society, and have done started doing research in the areas of pain management.
Dr. Cunningham?
So my name is Chris Cunningham. I'm an associate professor of pharmaceutical sciences at Concordia University, Wisconsin School of Pharmacy. The only one on this panel who is not a clinician, who is not directly dealing with patients. What I do is I am on the basic science and drug discovery side of the coin. So I do research in trying to figure out the mechanisms by which people become dependent or tolerant to opioids. And I also look at developing new medications that focus on opioid and cannabinoid neurotransmitter systems.
Dr. Miller.
Great. Well, I'm Mike Miller, and I've practiced addiction medicine in Wisconsin my whole career of almost 40 years. I was in Eau Claire for 6 years, and then for over 20 years I was medical director for the New Start Alcohol and Drug Treatment Program at Moderator before it was part of Unity Point. Then I spent 8 years at Rogers over in Oconomowoc, medical director for their adult residential rehab program and other services. I left Rogers earlier this summer, and now I'm semi-retired and will be doing some things that I've always sort of wanted to do. I'll be working in drug court in Rock County starting on Monday for a day a week, and I'll be doing some more teaching at the university. Trying to get a contract done for a paid gig rather than just volunteer teaching, which I've done for a long time. I'm a full professor in the clinical faculty at UW School of Medicine, Speaker of the House of Delegates of Wisconsin Medical Society, served on SHIP's Opioid Task Force, and I've been very active in all of this stuff nationally. I've been the president of the American Society of Addiction Medicine, founded the Wisconsin chapter back in the early 90s. And so addiction is what I do.
Thank you very much. So what I'm going to do is actually ask the question, and I'm going to start with one person, but I'd like you all to chime in, and I am going to kind of keep us moving along. So I'm going to start with you, Dr. Morris. So how quickly can a person become addicted to opioids?
Well, there are people who it is believed become addicted after single doses. That is not a commonly held belief that occurs often, but there are substantial amounts of information that suggest that once someone has used a certain number of pills, and that number is somewhere probably between 100 and 200 tablets, those individuals are at much higher risk for the development of addiction. Fundamentally, addiction would appear to be a biological event. We do actually have morphologically different mu receptors that have been actually linked to higher use of opioids in hospitalized situations. So it can be a very small amount.
So Dr. Cunningham, this is part of your research, correct?
Yes, as a matter of fact, it is. The field of pharmacogenomics, which is going to be along the lines of what we were just hearing about, is the idea that a different patient or a different patient population might respond differently to the same medication. But one of the things that we try to do, talking about mu receptors, is we try to figure out better ways or new ways to develop medications to hit these receptors that don't kind of trigger or spark a rewarding sensation. So I think, as we might talk about a little bit later, one of the things that we can definitely do is try to develop newer medications that don't have the same addictive potential. And so all of this diversion and dependence could potentially be avoided.
So Dr. Miller, you obviously deal at the end when people are, I shouldn't say at the end, but when there is an addiction. Is it possibly to be cured of an opioid addiction?
I would say no. It's a chronic disease. You don't cure arthritis or hypertension. I guess you could say that with a pancreas transplant, you might be curing diabetes. But it's a chronic disease and it requires long-term management. Relapses and remissions are part of it. You saw a slide this morning. It's actually a 20-year-old slide that rates of relapse and addiction are about the same as for other chronic diseases. Addiction is really stigmatized quite a bit. People think, oh, everybody with addiction relapses. Well, my goodness, everybody with asthma relapses. But when somebody has a relapse to asthma, shows up in the emergency department, people don't go, what are you doing back here? So the real key is management. Actually, I'd like to encourage you to think about addiction maybe somewhat differently than you have already. Even the first question is a very commonly asked question, but some of the concepts get mixed up. How long does it take to become physically dependent on an opioid? A couple of weeks. Okay, is that addiction? No. What is the period of time between first use or maybe regular use and the development of loss of control? We heard today less than a year. Well, that wasn't the data with things like oxycodone and hydrocodone before the high potency formulations were developed. With heroin, it can be less than a year, and with the ones that are so intensely rewarding, maybe loss of control can happen in less than a year, especially if somebody's using quite a bit more of the contents than they were intended to use. But the thing that I promote, the notion based on my clinical experience and research, is that addiction really isn't about drugs in the first place. Addiction's about brains. And certain people with genetic predisposition, when exposed to powerful rewards, may lose control, and those without that genetic predisposition may not at all. Now, life experience can affect how your genes get expressed. That's the epigenetics that we heard mentioned. And so some people will argue that people have addiction before they take a drug because they have the structure of the brain so that when you present these strong rewards, a chain of events happens in their brain that doesn't happen in their next door neighbor's brain that results in loss of control. But again, once addiction is present, can people go back to controlled use? The best research on that was done regarding alcohol, and the number is not zero. It's probably about 11%. Who are those people that can go back to controlled use? We have no idea. We can't predict it in advance. But by and large, the only recommendation we have for people who have addiction is just don't dabble. Again, we don't make the recommendation for everybody because it's not about, there are some intrinsic properties to the drugs, but it's really about the intrinsic nature of the brain of the person who gets exposed through the wisdom teeth supply or whatever supply.
All right, thank you. Dr. Morris, can you maybe talk about how you think things have changed over the last 10 years in prescribing and what's been going on in the physician-clinician community?
Well, I think there's no doubt that the physician community is well aware now of the magnitude of the problem. Everyone is well aware of the magnitude of the problem. 10 years ago, I sat with the assistant district attorney for Milwaukee County in a video that I was doing for the Milwaukee County Medical Society, and we were talking about opioid diversion. And at that point, it was a really quite remarkable issue. Nobody was really talking much about it. It's become incredibly key. The comments that the speakers have made about diversion are really essential. While addiction is definitely an issue of the brain, so it's his and my special interests. We deal with this thing up here. The exposure is something that we don't have to have. And 70% of people who will become dependent and actually move on to use illegal street products actually begin with prescription products. Their introduction to that reward system being triggered, they then are subject to it. And our problem is that we've created a large collection of those people, and we have to deal with it now. That They have been exposed, and they are seeking those other areas. So as much as we love the EPDMP's results, we're seeing less prescriptions, people are now dying of fentanyl deaths. And they didn't start on fentanyl. That's what we know.
So, Dr. Cunningham, that makes me go back to your research and think about how long before we see results from some of the work you're doing?
The work I'm doing, we're talking like decades. But essentially the amount of time between discovery of something new and when it gets into the clinic where they can be dispensed. So it's a long process. But I can say that there's a decent amount of research that's currently going on with developing potentially new tamper or crush-resistant formulations. That's a big deal when you take, let's say, an oxycodone or a tablet that was in your grandparents' medicine chest, crush it down, you snort it, gets into the brain much faster. We see time and time again that addiction and dependence happens when you have this massive rush of dopamine right into the brain. That happens when you crush and snort. So new tamper-resistant formulations is something that's happening a lot more nowadays. There are a few medications, opioid and non-opioid medications that are coming down the pipeline that hopefully we'll maybe get an extra look at. Coming back to fentanyl, there are certainly some issues with synthetic fentanyls, and if we have time, we can certainly talk about those. It's a massive enforcement and identification issue.
You know, Linda, the funny thing about listening to Dr. Cunningham, one of the things I'm doing in my semi-retirement, I actually I have a lot of time now that I didn't have 6 weeks ago. I've actually agreed to do a project, which is to write a book on the history of the American Society of Addiction Medicine. And I gave a big history talk a few years ago and had to read up about it. The federal government got into this in the 1930s and developed a major research institute in Lexington, Kentucky, whose original name was the U.S. Narcotics Farm. And the intention was to do research and find a non-addictive painkiller. And after the experiences of World War I, you know, we hoped there would not be World War II, but in the 30s, governments in Germany and in America were trying to find out non-addictive painkillers. It's been the search for the Holy Grail, and we're not there yet. And it may be decades further, and the cannabinoid system is a fascinating system to think about researching for this. But we're looking for all the benefits and none of the downsides. We certainly haven't found it, but whereas addiction is now talked about by everybody, it got talked about by presidential candidates. I remember Hillary Clinton saying, I didn't expect to talk about addiction, but when I go to town halls in New Hampshire, everybody's asking me about it. And Trump has certainly talked about it. Everybody's talking about it. Congress is going nuts passing opioid bills, just like our legislature began doing several years ago. People like me who've been doing this, never was a secret to us. The rest of the world is finding out. And whereas Chip mentions that 10 years ago, the topics to physicians were different, it wasn't that it was new knowledge then, it was the translation of that knowledge to practitioners that was beginning. The opiate epidemic began very nicely in the mid-90s, thank you. And it was going very strong at the turn of the century. And medicine in general wasn't rallying, and policymakers were nowheresville, and everybody was treating, you know, alcohol and cannabis, et cetera, as we should, and as we still do, okay? So now this tragedy has gotten a room like this full of people, and it's gotten employers really interested. But yes, prescribing practices have changed in the last 10 years, and we're glad, we in the addiction field, you know, we're sad, but we're pleased to see the opportunity for people to listen to some of the stuff that we've been concerned about for a long time.
So that kind of leads me to one thing that I have noticed with this effort that I think has been really rewarding for the 20-plus years I've been in the healthcare field is a collaboration between all the different clinical types. So maybe first, Dr. Cunningham, you could talk about it, but from your perspective, talk about how all the different clinicians are working together to try to help all of us, employers and parents and grandparents and whoever with this addiction.
Absolutely, and I think it was wonderful to have seen the previous talk just before this one where we saw done really well a conversation about the pharmacist's role in treating pain, in treating addiction as well. One of the things that I can say that a lot of my pharmacy students, the way that we train them to think is to think about the patient as a whole for one, also to look at medications, but then also to be communicative with the original providers. As an example, we heard some conversations about patients taking multiple opioids from multiple providers. Let's think, for example, about a person who maybe has a chronic back issue, but then breaks their leg. They might be getting medications for the chronic back issue from their primary provider, but maybe they've broken their leg and they are on vacation and they're seeing a different prescriber. Perhaps they're getting different opioids, maybe hydrocodone from one person and morphine from another. These are both opioids. They can both kind of cause extra risk for overdose. Benzodiazepines, if a person doesn't think about the word benzodiazepine, perhaps they don't know the term or they don't know that Xanax is a benzodiazepine, maybe they're not telling their prescriber, but the pharmacist is absolutely the person that we're seeing more and more is connecting with the clinicians to hopefully give more benefits to patients.
So Dr. Morris, tell me from your perspective, what do you think you've changed in your practice or seen your partners or others do to help?
Well, I wish I could say that I've seen radical changes. I hate to feel like I'm prescient or anything, but I didn't use opioids ever, and I still don't. So nothing to do with me. I chose a field of neurology where pain management wasn't a substantial component. So I've been blessed to be able to be free of that burden. But when I look at my colleagues, I worry about a number of things. I understand that there are circumstances where unremediable pain really requires management. Unremediable pain, cancer being the most commonly described, but there are many other forms of intractable, untreatable pain, such as in sickle cell crisis, such as in terminal arthritis. People get to the point where inflammation has ceased to be the major issue, and you are just dealing with massive activation of pain. And as a neurologist, I say, we have things that modify pain, so that's important. But I wish I could say that they're not simply running the other direction in the areas of, for instance, headache management and back pain management. But this is the dilemma that we will face in this whole process. I was raised, as Dr. Miller probably, in a period where opioids were something we were very cautious about because we had gone through periods of significant addiction. That addiction process actually began during the Civil War, the soldiers' illness. And so so as physicians, getting that balance is really the key. And we don't see that, and the interesting thing is, we don't see that in the rest of the world. Right? Mm-hmm. Right, guys? We consume the bulk of these opioids worldwide.
Yeah, the undertreatment in the other rest of the world is part of the reason that our statistics are so high. And the avoidance of opioids, our problem came in this country when there was very successful marketing of high-potency, long-acting opioids for acute pain. And that's where things went off the rails. But the use of these products were designed for cancer pain and for end-of-life situations. So people could take one pill instead of 16 pills when they were dying. The contents were great scientific advances, great clinical advances for a particular indication. When the market got expanded through some pretty fraudulent marketing, which has been criminally convicted about, that's when things really went off the rails.
But that leads me to a question
Yeah.
here. What can employers do? I'll give you an example. I've personally been dealing with some neck pain. So what I ended up doing is going to an acupuncturist because I've had success in that before. But my health plan, which I'm part of, we don't cover it. And are there other options or other things we should think about as employers to start including or, participating in to try to help with this issue?
There's no doubt about it. Chip and I are roughly the same age. We had the same type of medical education, though in different places.
You had to see his face.
I'm older than he is. Okay. But the general themes that were taught in this area were about the same. And there was the development of what we call interdisciplinary comprehensive pain clinics that involve mental health services, prescribing of opioids, prescribing of non-opioids, things like acupuncture, yoga, relaxation, meditation, just a wide range of services for the patient. And a lot of comprehensive pain clinics actually were very low opioid prescribers. Those clinics began to develop, and there were several in Wisconsin, and basically they all went out of business because the benefits stunk and they couldn't stay in business. But to open up a clinic that prescribed, you could make a ton of money. So the benefit structure needs to look at comprehensive pain clinics. And I represent Wisconsin in the AMA. I've done it for 20 years. And we had an excellent report on comprehensive pain clinics and the need to improve reimbursement for them, the benefit structures for them, so that you're not just getting reimbursed for either interventional pain or pharmacotherapy, but for some of the complementary alternative medicine approaches, the non-opioid meds and the non-medication approaches in general. There needs to be kind of a return to the past where we had these comprehensive pain clinics and the market still hasn't shifted enough that you notice, every hospital system in the state putting billboards on 984 saying, come to our comprehensive non-opioid pain clinic, but they should.
So that leads me to Dr. Cunningham. Do you have anything from the pharmacy side that you think could be done by employers to help?
So one of the things that I do natural products-based chemistry, and so there are a lot of good kind of herbal products that one could use. Certainly there are some things that are kind of calming. One of the things that is definitely a trigger for relapse or also can trigger cravings is going to be stress and anxiety. As a matter of fact, stress and anxiety could also exacerbate, let's say, a migraine. So along the same lines as what we were just hearing, and of course, here's where I have to have a little bit of disclosure, as my wife is a yoga instructor, used to work for Rogers, so a little bit of there. But anything that you can do in order to calm yourself or kind of enhance your body's and your brain's natural endorphin system. The runner's high, it's actually a thing. It's your brain and your body producing extra opioids. It's kind of producing your endogenous morphine, so to speak. So there's absolutely things, any treatment options would need to take a pharmacologic, but then also kind of a more holistic approach.
Dr. Morris, do you have anything to add that the employers in the room should consider in both plan design or even in the office workspace?
So from my standpoint, in this era, I see employers as a great cultural mover. Our culture gets moved many times by employers. Take wellness overall as an example. Employers understand the value of good employees, and their wellness, both mental and physical, is a key element of keeping those employees working. And so when I talk about what can employers do, they create a culture of appropriate pain response. What we really lack, in my view, overall, is the cultural adaptation that we're going to need to actually move away from kind of a pill-based approach to pain, which is what we got as doctors when everybody said we weren't treating pain well enough, and move on towards a more communicative step. My whole interest is in the area of health literacy, and I suspect, not only suspect, I know that pain literacy, the knowledge and awareness and the ability to use it, is key. So it's not just, you know that opioids are bad. How many times have we all heard that? Anybody not heard opioids are bad? The classes I teach on drugs of abuse and abuse, they all know, they can give me an article every single day about opioids. So we know they're bad, but how do we deal with the issue of pain? What does pain mean? What causes it? How do we modify it? It's many times those really important communications that have become so difficult as rushed practitioners to deliver. And one of the projects I'm doing is to actually engage community health workers as pain navigators for people who experience their first exposure to opioids, in the hope that we actually navigate them away from that as a response and navigate them towards this much more holistic Dr. Cunningham approach.
Yeah, I like what you said, Chip, because you threw in there the time pressures of what's happened to medicine and how short office visits are now and how little eye contact there is with all the computer screens in between. And so the ability of the physician to be the communicator and the motivator is limited by the structures we've created in the business of medicine. Employers are in a much better position to educate. And I've seen many slides today about the elevator talk, safe medication storage and disposal. It can be taught in schools, it can be taught in public service announcements, but employers, through the HR department, can teach employees about safe medication storage and disposal. You can really make a difference. The other is the cultural thing that Chip was 90% there saying, people in this country expect that when they have pain, it will go away. That's not realistic. Chronic pain doesn't go away. It needs to be managed. You need to understand it. You need to embrace it almost. You need to live with it. You need to roll with it. And the end point of pain treatment in chronic pain conditions, sadly, is not that you will not have pain. It's that you will improve your functioning and your quality of life. And employers need to let their employees know that. They need to deliver the message, you don't come back from medical leave when you're pain-free, because that could be waiting forever. And a lot of the meds that are used are really snowing people, so they don't notice that they're in pain. They may not be able to function very well, but they don't notice their pain because their whole central nervous system is subdued. That's not what we want.
So that kind of leads me to a question. I had a situation where I had an employee that I suspected had an addiction issue. What should you do if you're in HR or you're a manager and you have an employee that you think has an addiction issue? In our case, we made sure we said there was EAP and others, but what should one do?
Well, we've heard it all day. First, have a written policy so that you know what to do and you don't scratch your head and say, what the hell am I supposed to do? That you've already thought through the scenario and written HR policies about this so that you're protected when you approach the employee. You do want to have an EAP system, and you do want to be able to go to them and say, I'm really concerned about what I see. Your functional level is off, your level of alertness is off, your level of engagement with your peers is off, you look like you're getting isolated. I don't know what you've got. I don't know if you got depression or what you got, but there's something, you're not yourself. I really need you to take 3 days off, paid, go see your PCP, get a referral to a mental health person, go see if maybe there's a substance issue in your life. I don't know what you got, but get an evaluation. And as we heard our Illinois friend from the business group, just being able to talk about it. Just being able to talk about it. What's that big thing on your forehead? What's that great commercial, the nail in the person's head? Just being able to talk about it. I think that the culture in the employment world needs to be that this is something that you can talk about with safety. If you have policies that are written, then I think you're protected from the employee going, what the hell are you bringing that up for? Why are you singling me out? Well, if the policies really allow for the employer to, in a compassionate way, say, hey, I'm seeing something, I'm not sure what it is, but I sure would like you to get it evaluated. That's something you can do.
Dr. Cunningham, anything to add about, from your perspective, other things that you would add?
So I think that it was a great conversation. I would probably add in there, just kind of on the legal side of things. Obviously, one wouldn't create a policy kind of out of whole cloth. In the academic world, we try to do this all the time, and we fail pretty spectacularly at it a lot. So absolutely, I would say to make sure that you have someone who is abreast of the state and federal regulations. So somebody who is a regulatory expert absolutely should be a part of the conversation of developing one of these types of programs, policies.
Thank you. Dr. Morris, I am wondering, there's been a lot going on in the HOPE legislation, and from your perspective, what should government still do to help?
The role that government can have in this process can be multiple, but in many ways, I think it's to actually look for ways to improve the situation. And by that I mean not to engage. We don't need to go back to the era of a war on drugs. I'm old enough to remember there was a war on drugs. Some of us weren't born yet.
There was still a war on drugs when I was born.
Okay,
I'll say that.
right. So that we need to think about mental health, and I mean mental health, not mental disease, the presence of the lack of mental health, but mental health the way we think about physical fitness. John Kennedy put together a program for physical fitness, created the President's Council on Physical Fitness, and it was everywhere. I had to do it. I suspect that...
Oh yeah, jumping Jackson Elementary School.
Yeah, running around and seeing how slow I can be in the mile. That kind of mission for the country is what we need to exert on our mental health. And again, I'm not talking about looking for disease, which we'll find, because we don't treat mental health. But we work together as a group to be healthier mentally. And that starts in schools. It starts everywhere you go. Can the government have a role in trying to help design us to actually think about our mental health like we would our physical health? It can. It hasn't been really terribly successful in the physical health sphere as our country is growing, and I don't mean in a good way. So obesity is the catastrophic epidemic that we don't pay attention to, but it's right with mental health. We don't take care of it. What can government do? That's what Representative Nygren can do for me, is he can create a absolute priority that every Wisconsin school teaches about the way you manage your mental state and your health.
Dr. Cunningham, anything from your perspective?
Yeah, absolutely. So I do research, and so I'm on the bench. And the number one place where we get our funding is from the National Institutes of Health and the National Science Foundation. NIH in particular, the National Institute on Drug Abuse, NIDA, as well as the National Institute on Mental Health, NIMH. These are two places where a lot of this basic science research, all of the treatments and the cures, the 21st century cures we heard about, that's the place where all of this starts. And like I said way early at the beginning of this talk, it takes decades for me to come up with something neat. I can't come up with anything neat if it's not funded and if it's not supported. And one of the exciting things is that just in the last president's budget, $500 million in additional, $500 million over the requested budget for both NIDA and NIMH have been earmarked specifically for opioid research for the next 2 years. That's pretty substantial, and that is, I think, a great investment of the treasury that we have in order to try to lick this disease. So I think definitely the government can play a role in supporting the development of new cures. Another thing is kind of opening up a little bit of freedom for people like me to do research with opioids and cannabinoids. As we heard earlier, great talk from the pharmacist, there are schedules. Schedule 2 is where a lot of opioids are. Schedule 1 is where a lot of cannabinoids are. I can't do a research trial, for example, if I were to want to, with a drug like cannabidiol, which could potentially have anti-pain effects. I can't do that without a special type of license, which could take years in order for a single protocol to be approved. So a government can afford researchers like us extra opportunities to allow us to do these sorts of research. And this is a sort of thing, again, where Congress, state, local legislatures can try to maybe grease those wheels a little bit and try to just free us up a little to do legitimate research.
So that might be something employers could lend their voice to, is money that would be earmarked for research. Dr. Miller, Dr. Morris touched on this, but what are we going to do to help dispel the stigma of mental illness? What's the answer?
Well, I'd be sitting in a different chair if I knew that answer, because it's, you know, it's really a challenge for our culture. It's a challenge for the human race worldwide. Stigma against mental illness and addiction may be larger in some other countries even than it is in our nation. I do think that Chip is onto something. I mean, I really like education. Of course, I've been to school a lot of years of my life, and my kids have been, and I paid a lot for it. But you shape the way people think by education. Now, libertarians say, don't make us think a certain way. Let us be free to think the way we want to. I think elementary school, middle school, education programs about mental health, mental wellness, how to cope with stress, how to resolve conflict, how to spend time alone. There's projects in Madison being done right now by Richie Davidson's group on preschoolers with regard to using meditation. I think that the school system, in just changing the culture and not trying to change the minds of people with rigid negative thinking, just let them die off and get a new generation of people that think a little bit more openly. Okay, I mean,
from opioid addiction, yeah.
But no, I can say that stigma has been the biggest fight from the beginning. The National Council on Alcoholism was started in 1940 to deal with stigma about alcoholism, but there's still stigma there to this day. And there's much more stigma about drugs in general, and injection drug use is maybe the most stigmatized. There's huge stigma about medication treatments for addiction. And so the government can help with regard to expanding treatment opportunities for medication-assisted treatment. I do think though, Linda, that again, from where I sit in the 35-plus year career that I've had, most addiction treatment in this country has been paid for by the public sector. It's been paid through federal block grants. It's been paid, which don't exist for any other health condition. It's been paid for by Medicaid. The private sector has sat on the side. One of the lines that I've used is that the public safety net has allowed the private sector to not have guilt. Health systems in our state, the big ones, do they have addiction departments? They wouldn't think of not having a dermatology department, but they've thought all along, we don't need to have an addiction department. The public sector will take care of it. The treatment needs to shift from the public sector and the government world to the private world of all the health systems whose names you know. But the government can fund research and the government can fund training. And what we need is more training for people in mental health and addiction areas. And I've been very involved with public policy for a long time. We're on the cusp of a big bill in Congress to get 10,000 residency slots filled to help deal with the opioid epidemic. We have a wonderful addiction medicine fellowship here at the medical school where I hope to be spending a lot more time. There's some specific funding that's come from the HOPES legislation about funding various health professions in understanding addiction more. If your doctors and your nurses and your pharmacists and your psychologists don't understand addiction, you shouldn't expect your storekeepers and your tradespeople to know about it. We've got to get the health community better educated because they haven't been to this point. And so the government can fund educational opportunities in these areas.
So with that, I am going to turn it all to you and ask, is there a question you wish I would have asked one of these panelists? So, are the mics live out there? So don't be shy.
I want to ask you a question. Who has been touched by addiction? Who has lost a family member to addiction? Look around, folks. It's not that uncommon. My cousin died in the parking lot of Walmart on Christmas Eve with his Christmas presents for his 2 children in the back seat from a heroin overdose. And I will absolutely assure you that you do not have to look far. But again, Dr. Miller's career is a paragon of really a devotion to the mental health that people have, not the correction of illness, but their actual mental health. And that's what we need to devote ourselves to. Argue with me. Somebody get up at a microphone and say, nah.
Well, I would just love, what question
Yeah,
do
somebody
you
fight with me
have?
because she'd love to see that.
I have a question.
Yeah.
In the last 6 months, in a space of 1 week, I had 3 employees come to me and say, I cannot find a mental health provider for my child. And so I'm listening to the panel, and it is occurring to me that perhaps we're putting all our eggs in one basket, mental health provider basket, instead of the whole medical profession, and wondering and getting total buy-in in treating mental health. And so I'm feeling my perspective is changing because of your panel, that we shouldn't target mental health professionals as the only place to go, but find other specialties that can help us. And
I completely agree. Now, I'm going to tell you a little vignette here. We know what's happened in adult mental health. Child mental health is a tremendously underserved area. But in adult mental health, what we've seen, and my career parallels it, the discovery of Prozac, a well-tolerated antidepressant, teaching primary care docs that depression is something you can do. I mean, I remember when the push came to teach primary care, this is something you can do. You can treat depression. And now, the vast majority of depression is treated in primary care, but not by specialists. In the addiction world, buprenorphine, Suboxone, and other products you've heard about, came onto the market really pushed by government. Okay, really pushed by government with a big act of Congress in 2002. The idea was to get primary care docs to be able to prescribe buprenorphine so you wouldn't have to go to a methadone clinic. Down the hall here is a big conference on perinatal addiction. I walked in there today to get my name tag. They told me, you're not here. And I went, what? I'm speaking. So I have a whole bunch of friends down here at this big conference on perinatal addiction, dealing with pregnant women. A person in there is a friend of mine who's invited me to come to the Monona Terrace and speak in April to a civics group on addiction and what's the treatment. She's retiring from primary care now, and we've been in this email exchange. She says, don't you dare suggest that primary care take up the mantle of dealing with addiction. We have so many things we have to do already. You'll drive people out of practice if you tell us we have to do this. This is what you're dealing with. Primary care is scared, and the reason is they weren't taught anything in medical school. So if they're already in practice, they just feel a burden. But we can teach a new generation of primary care that don't say this is somebody else's job, this is your job. And so dealing with mental health, dealing with addiction, I completely agree with you that mental health is health. Addiction is health. And it needs to be done by the health system, which is my economic discussion earlier. And it needs to be done by everybody. And in medicine of all, people shouldn't be saying, that's not my deal. Well, I think it is your deal. Thank you.
So we are at our time, Cheryl, I see that. Can we have
Sure.
one more question? That would be great.
Yeah.
You. One of the things that I was wondering about is, are you aware, are there any mechanisms in place for families of cancer patients, part of that take back? You know, in so many of the slides, we see pretty much unlimited use of the biggest heavy hitters in cancer cases. In the last 9 years, I've lost 2 family members to cancer, and I can honestly say, you know, sitting in the household with them, and they're working through the bereavement process. There's so much going on there. It was astounding to me, the amount of fentanyl patches and, you know, recently filled prescriptions. We filled those prescriptions right up until the day my dad passed. And that afternoon, we're sitting there looking at the counter full of medications that we had. Are there any structural mechanisms in place that you're aware of for people to circle back and suggest to the families these take-back programs?
We're getting there. Everybody needs to be on the bus. Everybody needs to be on the bus. So the oncologists need to be on the bus. The nurses that work in cancer clinics need to be on the bus. There need to be educational programs that all health systems develop to describe that exact scenario. I mean, I would say that a quality measure in any health system is when you understand you have a patient under a palliative care plan, that this is one of the things you have to target. You're going to have to work with the family. We actually had to get some laws changed to allow people to go into the home and get stuff. It used to be only police could touch it. But there need to be mechanisms so that the case managers will come and say, let's do some house cleaning. And so I really welcome your question. People just got to think. But that's a very real world example. And if it's not done, the grandkids' friends know where it is.
Or the grieving spouse.
And the grieving spouse. And it brings up another issue about epidemiology that was touched on a bit. The deaths from the prescription pills, the peak is 40s, 50s, and 60s white males. Okay? And you would think it would be maybe younger people, and the big stigma is people of color. What we've learned is that stigma has been protective for African Americans because they're not prescribed pain meds because doctors think they're all going to be junkies, and it's based on racism. And they have less opiates in the home, and there's less deaths. It's a crazy scenario, but it's true. I didn't make it up. So the issue here is Narcan has to be available in all those homes. Everybody needs to know about the risk of overdose. Now, the cancer patient overdosing, maybe if it's end of life, that's not what you're trying to prevent, but there could be accidental overdoses by others, and the bereaved spouse and the suicide is a huge issue. So Narcan isn't just for IV heroin users. Narcan is for anybody prescribed large amounts of opioids, and co-prescribing of benzos, we've heard, is something that needs much more attention, and that's a no-no. Co-prescription of naloxone with opioids is a yes.
Okay, with that, I'm going to close off, but thank you so much to our panelists. Really appreciate your time and energy.